Hello, everyone, and welcome to today's webinar on addressing health inequities in promised neighborhoods. My name is Peter Tatyan. I'm a senior fellow at the Urban Institute and one of the co-leads for the Urban Promised Neighborhoods Technical Assistance Team. So this webinar was originally scheduled for our annual conference this past December, but unfortunately we had to postpone it. So we're very delighted to be able to bring this conversation to you today. Um, During this session, we're going to talk about how social determinants of health interact in our communities and how education specifically affects health outcomes. This event is being recorded, and the recording is going to be posted online afterwards so that you can share with others who may be interested or watch it again yourself. Speaker biographies are available online at urban.org, and a link to the bios will be posted in the chat. We have closed captions turned on. If you'd like to adjust your settings, click on the live transcription button at the bottom of your Zoom window. All participants are muted today, but you can send questions or comments in the Q&A box at any time, and we hope to have enough time for audience Q&A at the end. And finally, if you tweet about the event, please tweet using the hashtag #LiveAtUrban. So it's my great pleasure to be able to introduce the moderator for today's discussion, Joshua M. Sharfstein. Josh is the Vice Dean for Public Health Practice and Community Engagement, Director of the Bloomberg American Health Initiative, and Professor of the Practice in Health Policy and Management at Johns Hopkins University. So I'm delighted to turn things over to Josh.
Here we go. There I am. Thank you so much, Peter. It is such an honor to be here and to moderate what's going to be a really interesting and important session. I think we should have the next slide up. I will put it up here. Hold on one second. Just 1 second. This is a slide of the social determinants of health from the Urban Institute, which is the topic of today's session. Now, before I was any of the things in my introduction, I was a pediatric resident. I'm a pediatrician. And when I was working at Boston Medical Center, it became incredibly clear that the biggest threat to the health of the children that we were taking care of wasn't going to be an ear infection or a normal childhood illness, but was actually the housing conditions in where the kids lived. And the pediatric residents systematically examined the housing conditions. We talked to other pediatricians and parents about the housing conditions and the impact on kids. And we advocated for policy solutions related to housing, not just typical pediatric topics. And that was my introduction to the concept of social determinants of health, that the social conditions, in the words of Michael Marmot, predict and contribute to health more than health may contribute to the social conditions. And you can see in this Urban Institute graphic that there are concepts behind the social determinants: equity, power, dignity, and fairness. And there are topics, including housing, employment, social care, education, safety and justice, healthcare, food and nutrition, and income and wealth. All of these things wind up being important drivers of health and well-being for populations. Now, the Promised Neighborhoods Initiative is this incredibly important national effort to really focus resources and improve health and educational outcomes. And in order to be successful in improving key outcomes, it is necessary to pay attention and address social determinants of health. So today we're going to hear from two people with central roles in two different promised neighborhoods. And we're going to talk to them, and you'll have a chance to ask your questions about how they thought through this issue of underlying social drivers of health as they were trying to have clear impacts in health and education and other related outcomes. How do you actually do that in practice? So this is going to be a roll up your sleeves conversation with two really terrific people. So I'm going to introduce them and we'll get going. First, we're going to hear from Stacey Stevens, who is the director of the Be More for Healthy Babies Upton Druid Heights program at the University of Maryland School of Social Work's Promise Heights initiative. Be More for Healthy Babies is a citywide effort to address birth outcomes and healthy childhood across the city. And it has focused on a particularly high-risk neighborhoods, of which Upton Druid Heights is one of them. So Stacey Stevens runs this program, which works with meaningful partnerships with residents and community partners to address the infant mortality rate. And you'll hear from her about just how much success they've had. It's really been an amazing story, recently announced by the mayor of Baltimore. She has over 26 years of experience in assisting underserved women and children gain access to medical and mental health services throughout the Baltimore and DC metropolitan area. She's a clinical instructor at the University of Maryland School of Social Work and an adjunct professor at Morgan State University School of Social Work, where she teaches and inspires future health professionals. She was appointed to the Maryland Task Force to study perinatal mental health by the governor. And she's also a certified diversity practitioner, which enables her to help individuals, groups, organizations, and communities effectively manage cultural differences, influence system change, and create equity in healthcare and education. After we hear from her, we will hear from Amy Carroll Scott, an associate professor in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. Her research focuses on understanding and addressing urban health inequities and their social determinants by employing social, epidemiological, and mixed method study designs in partnership with community anchor institutions. She co-leads the evaluation of the West Philadelphia Promise Neighborhood Initiative. So first, we'll hear from Stacey Stevens about the Baltimore Promise Neighborhood effort, and then we'll hear from Amy Carroll Scott about one in West Philadelphia. And we'll hear from them about what they're actually aiming to do and how social determinants play a critical role, what they've done to be successful to address social determinants in order to achieve the outcomes that they're seeking. So with that, I will turn to Stacey Stevens. Stacey?
Thank you, Dr. Sharfstein, for your wonderful introduction. And I would like to thank our staff and our team and our families who have really trusted us to do this work with them in reducing the infant mortality rate and improving health outcomes in our Promise neighborhood in Upton and Druid Heights. So during today's presentation, I'm going to share how social determinants of health contribute to health inequities in the communities of Upton and Druid Heights, which are located in Baltimore City, Maryland. It's out of the neighborhood where we do our work. And I'm really going to be focusing on our work during the cradle portion of our work, which is the portion of the work that I lead, impacting birth outcomes, and I would dare say maternal health outcomes as well. Many of the strategies and interventions that we are sharing are really due to a collective work at every level of system, at the city level, at the federal level, and due to a lot of work by residents that has led to this tremendous outcome. Next slide, please. And so first I want to just show you the demographics of Maryland, the US, and Baltimore. Many of you may have traveled to Baltimore and you know that, or to Maryland actually, and you know that Maryland is one of the wealthiest states in the country as seen by the median household income. However, when we look at Baltimore City, we see that residents are living in areas in social conditions where there is deep poverty, pretty much like 2.5 times more than other parts of the state of Maryland. And definitely in starting out this conversation, we're recognizing that socioeconomic status is a determinant of health. And so Baltimore City is comprised of about 250 neighborhoods. And like many of the other Promise neighborhoods who were on the call this morning, in your various cities around the country. As you travel around, I'm sure you see and experience many of the social conditions that we will highlight during today's conversation. And so what you will see is that you will see residents and families, and if you work in those environments, in those neighborhoods, you are seeing a tale of two very different cities or geographic regions or areas. And so our work is centered in the communities of Upton and Druid Heights, where there are approximately 10,000 residents. 92% of them are African American. And the median income is $22,000 per $225 per year. 45% of the residents live below the poverty line, and 63% of children live below the poverty line. And the life expectancy of residents is 56.7 years of age, which is the shortest in the city. Next slide, please. So for the past 10 years, back up, right. For the past 10 years, Be More for Healthy Babies at Promise Heights, out of the School of Social Work and School of Medicine, has worked to ensure that every baby born in those two communities is born healthy and able to live in a thriving family. The communities of Upton and Druid Heights was selected when this Baltimore City Health Department, Family League of Baltimore, and Healthcare Access Maryland, when they were figuring out the plan of action to address and improve infant health outcomes, which is an indicator of community health, Upton and Druid Heights was selected as two of the 12 neighborhoods that had the highest infant mortality rates in 2011. When Be More for Healthy Babies, the citywide initiative started, Baltimore City had the fourth worst infant mortality rate in the country. In that year, 128 babies died. 27 of them were related to unsafe sleep conditions. And there was Black babies die at a 5-time rate higher than white babies. And so for the communities of Upton and Druid Heights, when we started our work in 2011, the infant mortality rate was 15 per 1,000 live births. And so at that point, we recognized that we had work to do. Next slide, please. And so Be More for Healthy Babies, back up one slide, sorry. At Promise Heights is an academic and community-based partnership that I mentioned earlier. We do this work across a pipeline of services that is really aimed at improving the health, social, educational, and financial well-being of residents of the communities of Upton and Druid Heights. Be More for Healthy Babies is the cradle portion of the pipeline. We have, over the past 10 years, worked in schools primarily, where families are in the neighborhood, and we actively engage and collaborate and support expectant families and families who have children ages 0 to 3, and we work in partnership with faith leaders, business owners, schools, and health practices to improve maternal and infant health outcomes. We have fortunately been funded generously during this time by Care First Blue Cross Blue Shields, and over the past 3 years by Promise Neighborhoods funding. And so this funding has helped to support the work that we've done. And it's really been to address the determinants of health, as we know the lived conditions upstream that have occurred across generations in the two communities in which we live, in which we work. Be More for Healthy Babies is our staff is comprised of perinatal health workers, certified lactation counselors, social workers, peer leaders, and students from our various graduate programs. As you look across the pipeline, Promise Heights staff include social workers at the community schools in which we do our work, early childhood and mental health specialists, AmeriCorps members, and parent leaders. The next two slides that I'm going to show you are really going to reflect some examples of social determinants of health. And then I will share specifically how they impact health outcomes, particularly related to infant health outcomes. And so what I want you to stay attuned to is that these, once again, are lived conditions, built environments, not residents, okay? And so first we have a map of Baltimore City, and the start area kind of pretty much shows Upton and Druid Heights. The highlighted areas, if you can just click one time, the L shows the white L, which was coined by Dr. Lawrence Brown to illustrate the areas in Baltimore City where the wealthier communities exist and where there's a longer life expectancy and many more resources and wealth. Tap again, please. This denotes the butterfly, the black butterfly, in the same example that Dr. Lawrence Brown spoke of. And this really kind of reflects the many challenges that residents face due to generations of what I call intentional residential disinvestment and the cumulative impact of structural, economic, and political disadvantage. The lived environments and conditions impact racial disparities that we see in health and also educational outcomes. Click the slide, please, and just bring up all the maps, please. All right. So the white L and the black butterfly can be traced to discriminatory redlining practices. And many of you can find these history of redlining in your own country, in your own communities, and you can see how it impacts the lived environment. Who has housing, who does not have housing? What areas are blighted in the communities? Which areas are being gentrified and thriving? And so in these maps, when we're looking at them, we're seeing how it reflects vacancies, food apartheid, and incarceration. So if you're looking in the area where the star is, that denotes the communities of Upton and Druid Heights. The deeper the color on all those three slides reflects the opportunity, as we're on this call together, for the greatest change and how we can engage and work differently around how we do our business in communities and do the heavy lifting to disrupt these social conditions and built environments, okay? And so we have come to learn that housing and health are inextricably linked. Upton and Druid Heights, as I mentioned before, is in a red line area. Racial residential segregation housing continues to persist today. As you can see, there are high level of vacancies. We also know in health that when a community is blighted, it leads to elevated blood pressure in residents, impacting not only birth outcomes, but outcomes across generations. The stress of having inadequate housing, unsafe housing, is a real stressor for many residents. And it has been reported not only by residents, but also those who do the work in the community, our perinatal community health workers, and also our home visitors. And what this does is that the stress wears on not only expectant mothers, but also on other residents, our elderly who are in those communities as well. You see here a slide addressing food apartheid. And food apartheid we have come to know as the systemic destruction of Black self-determination in order to control Black food, land, and resources. Food apartheid can include hypersaturation of destructive foods, the scarcity of nutritious foods, and predatory marketing of unnutritious food, food that is elevated in fat and in sodium. And all of these impact health outcomes. And I want to pause here and say, particularly for expectant women, we have come to find out that the lack of available adequate nutrition, along with stress, lead to elevated blood pressure. And in doing so, it is a significant driver of some of the disparities that we see in low birth weight babies and very preterm babies. Next slide, please. So when we're looking at the next three slides, we're looking at higher levels of lead exposure rates, the number of 911 calls for shootings, and the state spending on incarceration. Again, you can see the circle areas that show Upton and Druid Heights. Again, these are all factors that we call and know as social determinants of health. And so the higher exposure to lead level, which oftentimes is found in pollution and old housing, can lead to basically harming pregnant women, risk of miscarriage, preterm birth, and having a low birth weight baby, and also impacting a baby's ability to develop fully. And for everyone who is working in education, as many of you are, it also can lead to children having learning and behavioral problems. Again, lived conditions. Community violence in Upton and Druid Heights, high rates. We see this occurring with high shooting calls and having those who have been formerly incarcerated also residing in that community, also high rates of non-fatal overdose rates, leads to tremendous stress for residents in the sense that it sends ripple effects in communities, anyone working in communities, anyone living in communities. It also leads to a heavily surveillance community, and all of this impacts health outcomes. Next, one slide that I didn't include was really showing, you can leave it right there, showing the lack of tree canopy in many of urban environments. And what we've come to find out around when there is a lack of tree canopy, lack of tree covering, then those communities in urban areas, the temperature is hotter, about 10 to 13 degrees hotter. And that impacts birth outcomes. It increases families who are at greater risk of having exacerbations with asthma and other respiratory issues, and also elevated blood pressure. Okay. All of these factors and many more that we'll discuss shortly interact with the environment of trauma and social location. All right. And so we can't have these conversations without raising the role of chronic exposure to stress and trauma and how it impacts on health and how it impacts on educational outcomes. And so when you're looking at these two slides, I want you to pay attention to how the chronic exposure to racial stressors, microaggressions, implicit biases that are embedded in many of the structures that we're going to talk about today, and they are the root causes around adverse community exposures that those who live, work, worship, play, and learn in those conditions impact and accelerate the aging process and really hamper or make it difficult for the stress response to perform adequately. And so it decreases life expectancy and also health and well-being across the lifespan, meaning, and also across the life course, meaning the next generation. Next slide, please. And so what we've learned to do, many of us are coming through a period of pause and dealing with the pandemic of being socially isolated. But we have learned in the communities of Upton and Druid Heights and the work out of Promise Heights to really embrace the power of a pause, because it has been in the power of a pause, in stopping ourselves and breathing deeply. We'll talk about some of this later on. And it has really impacted our ability to listen effectively to residents who live in the community, to what they're saying, and to take their instruction for the change that they want to see and implement those changes in many of the interventions that we will talk about. And I also want to
Professor Stevens, I just mean to jump in, let you know you've got about 5 minutes or so.
Okay, that's fine. I'll be done in 5 minutes.
Great.
Thanks. Next slide. And so in that pause, we are able to see how we are disrupting the impacts of social determinants of health, trauma, and I've not mentioned racism, but definitely racism as well. And so when you're looking at the various determinants of health, we have implemented rental assistance programs that are helping residents not to have stress around how they're going to pay to live in their homes, in their apartments. We have implemented and provided food for folks, nutritious food, through food banks in the schools and also by making door deliveries. We have addressed economic issues, socioeconomic status by employing and training expectant families and mothers who've gone through our program to become certified lactation counselors and doulas, and really helping them to join the workforce and earn additional money in hopes of raising themselves out of poverty. We have also addressed how the mental health and well-being of residents has been impacted by providing mental health first aid training and mental health services readily available to residents. And so those are some of the interventions. Next slide, please. And so over the course of this work, we have been quite successful. We have been able to reduce the infant mortality rate within the communities of Upton and Druid Heights by 75% over the last 10 years. Next slide, please. And to now where we have a rolling average of 3.8 as that infant mortality rate. And that rate is pretty much the lowest in the city. It is incredibly low for our state. It is definitely lower than the indicator of Healthy People 2030. And we've only been able to do this largely because of the accomplishment with our work with residents and our partners. Next slide, I will show our highlights of some of our partnerships when we have the discussion in a few minutes. So this just kind of highlights other successes that we've experienced across the pipeline of services within Upton and Druid Heights. Next slide. This shows the spectrum of services that Be More for Healthy Babies Upton and Druid Heights provides. And so I want you to share with you that this work is intergenerational. It's not just focusing on a woman when she's pregnant, it's focusing on her across, while she's pregnant, before she's pregnant, during her pregnancy, and even after, and working with influencers and everyone else in the community in order to obtain and achieve those outcomes. Next slide, please. And I'm going to skip this slide because we'll cover this during our discussion. And so the last slide I want to show is that in this work, we are poised now, and we are doing this now. We are really looking at residents, our smallest residents, their parents, and our partners to sustain this work in Promise Heights. They have been deeply involved, deeply informing the work, and they are in the position now and are leading much of the work that we're seeing in Be More for Healthy Babies through the pipeline of Promise Heights. And that concludes my presentation. Thank you.
Great, that was so fantastic. I think you've given people a good understanding, Professor Stevens, of why you and your team are so appreciated and recognized as heroes, including by the mayor recently, for the work you've done, not just for how you conceptualize the problem, but for the commitment that you've shown and the team has shown working with so many people in West Baltimore to see these kinds of outcomes. And you've also indicated how the social determinants of health aren't an afterthought. They're integral to how you've been able to be successful. And I think it's just right on the point of this session. So now we'll turn to Professor Amy Carroll Scott. Dr. Carroll Scott, are you ready to go here?
I sure am.
Maybe if you want to set the stage for what is happening in West Philadelphia and the role and your thinking about social determinants of health there.
Absolutely. And given that I want to leave time for discussion, I'll try to make this as quick as possible. If you can move to the next slide, just want to give you a little bit of a background on the West Philly Promise neighborhood. Like Baltimore, it's an area of West Philly that's predominantly African-American residents and who are living in dramatically higher poverty levels, over 30% in some of these neighborhoods, high rates of unemployment, over 16%, and lower median household income, less than $25,000 a year for a family of four, and a lower proportion of residents 25 and older without a high school diploma, about a quarter, relative to other Philadelphia neighborhoods. And Philadelphia does poorly when compared to other US cities and the US as a whole. So like Baltimore or areas of Baltimore that were just described, this is an area that is very much shaped by systemic racism, residential racial segregation, generations of disinvestment and economic exclusion. And so this is the area of focus for our West Philly Promise Neighborhood Grant. It is focused on the same footprint as the HUD designated Promise Zone. So the idea was to try to leverage the kinds of partnerships and coalition building that were happening around Promise Zone and around housing, economic development, and public safety, and then to bring an education lens to it. And so what you see here is that we've distilled the required results that the Department of Ed has for us Promise Neighborhood grants, and I see a lot of my Promise Neighborhood colleagues here as participants. And we distilled these into 5 initiative goals that you see here. We have a variety of programmatic strategies that directly support each of these 5 goals, and then a few systems level interventions that are meant to knit these strategies together and be able to work on each of these goals together to provide a system of supports for children and their families who either live or attend school in that Promise Neighborhood footprint that you see in the map there. And so our activities happen in neighborhood schools, and we have 7, at child care centers, at after school and summer programs, at community centers and rec centers, at local nonprofits or anchor institutions, faith-based organizations and community-based organizations, and is led by Drexel University, which is located right in the center of these neighborhoods. Many of activities are centered at our urban extension center called the Dornsafe Center for Neighborhood Partnerships. So just to give you a little background, I have been working in social determinants of health throughout my entire career for over 25 years. And why am I involved in a US Department of Education grant? Well, because to me, everything about Promise Neighborhood is about social determinants of health. Social determinants of health are, in our minds, everything that that we are required to measure, and which I'll show in a second, all of the impacts that we're required to have, and all of the strategies that we're employing. But those that, to me, really address the social determinants of health are those that are working throughout the life course, from early childhood and beyond, from cradle to career, including multi-generational interventions, because that's how we see the transmission of poverty and poor educational and health outcomes. And also those that are cross-sector or cross-system in nature. So I'll just highlight one example. Our community resource coordinator and youth engagement coordinators are really working across all of these goals. They are using a community curated list of assets for children and families in West Philadelphia, and our connections to those organizations and programs. They are conducting outreach and working with families throughout our footprint here to be able to listen to what their household needs are and be able to connect the caregivers and the children to the variety of assets, programs, services, and resources that they have at their disposal. So working across sector and providing that kind of care coordination across systems, whether they're behavioral health, access to medical care insurance, educational supports, adult education supports, or career development supports. They're the ones that are at the epicenter of the systems level interventions that we have in the West Philly Promise Neighborhood. And I can answer any questions about these interventions as we go along. But if we could go to the next slide. I too mapped our GIPRA work to the social determinants of health model from the Urban Institute. And what you'll see here is that we primarily measure success of our initiative goals with these GIPRAs, and that we've mapped the GIPRAs onto this to show where these broad set of indicators fall within the social determinants of health framework. I'll be honest and say to you that I see that all of these GIPRAs are social determinants of health, which ultimately impact the immediate and lifelong physical and mental health status and well-being of each child, their family, and the community as a whole, which is represented by health and well-being in the central circle. I know my educational colleagues would say that all of these are social determinants of academic success and educational attainment, but I think we'll all agree that all of these major developmental experiences in childhood and over the life course contribute ultimately to economic success, emotional well-being, civic engagement, health, and other positive outcomes, which is what we want to see for our residents. Either way, it's interesting to note that none of the GIPRAs are actually measures of mental or physical health status. The closest we get are GIPRAs 8 and 9, which look at diet and exercise, and GIPRA 1, which is about children having a medical home. And so we actually have added robust caregiver and child health measures to our data and evaluation infrastructure, which I'll be happy to speak with you about as we discussed during the panel. Next slide, please. So I just want to show you how we're doing in meeting our initiative goals by looking at the GIPRAs between baseline, which was 2017 for us, and our last time point for all of these data, which were 2019, due to the fact that we're in the field right now collecting data for our last wave of caregiver family surveys, and also due to data challenges from the School District of Philadelphia last academic year due to the pandemic. So I'm not going to go through all these. I just want to give you a few giveaways. First, this is a population of children with low indicators of academic success, as evidenced by kindergarten readiness, math scores, and ELA, or English Language Arts scores. Although we're within about 5% of hitting our targets for the latter two, these are still quite low compared to district goals and national benchmarks. Second, I want to point out that this is a population for whom only about a quarter are meeting diet and exercise behavior recommendations, or GIPRAs 8 and 9. While we're close to our targets as of our last data point, these targets are quite low when compared to CDC and USDA guidance, and again, national benchmarks. Third, there are three measures in which the population is doing very well. The first is GIPRA 1, that the child has a medical home, and we attribute this to the fact that Children's Hospital of Philadelphia is nearby, and its CareAbout clinic is very accessible and in the same geographic footprint here. The second is that the child is in some form of childcare, and we attribute this to our Cross Systems Action for Early Learning initiative that works with 29 early childhood education centers and family ambassadors in order to help them improve their capacity and increase their quality ratings and increase awareness of high quality centers. And the third is daily attendance in schools. And we attribute this to the district's focus on this measure and associated solutions at the district level. However, since the chronically absent measure is still quite high, there's still attendance issues to address in this population, which we are exploring. And then the last takeaway, of course, is that these data don't reflect what's happened since the pandemic began. Due to the data capacity issues that I mentioned at the district, we're in the process of receiving last school year data, but the attendance data will be incomplete and of poor quality due to a systemic lack of access to Wi-Fi and Chromebooks last academic year. And that's why we were able to pivot with our Promise Neighborhood outreach staff in order to be able to provide Chromebooks, Wi-Fi access, computer access, and the like for families in our footprint through our Digital Navigators program. And then clearly we can expect most of these measures to worsen as a result of the pandemic. In fact, we did conduct a rapid COVID household needs phone survey with the subsample of the caregivers and families in the Promise Neighborhood footprint. And if you can go to the next slide, we found significant employment impacts among our subsample of 151 caregivers. You can see here that a very large proportion have been laid off, lost hours, and lost income. And 2/3 are essential workers, which of course put them at increased risk for COVID. And if you can go to the next slide. And this already at the time of our collection of that COVID survey last summer, this had already translated into household financial hardships, including paying for basic needs, utilities, rent, or mortgage. And you'll see our population fares worse than national data generated by the census COVID household pulse surveys. This is translated into food insecurity and to others. And just as an example, our 53% of these households couldn't meet basic needs, whereas the national average was 43%. If you can go to the next slide, I'll just wrap this up so we can get to the discussion. So I just want to take a moment to talk about the fact that even before COVID and even more since, our goal number 4 is really the one that is most critical to our success. What we know about our cohort of kids and families is that the major impediments to all the other goals here, kindergarten readiness and academic success, are exactly the same social determinants of health that have long been the drivers of health inequities throughout this country, and especially in urban environments like West Philly. And these include parent employment and economic stability, stable, healthy housing, access to behavioral health services and resources for all family members, and safe, economically stable communities. In fact, just in the last few months, our homicide and gun violence rates have more than doubled since 2019. I know other urban environments are experiencing similar gun violence epidemics. And so these are the day-to-day concerns of the caregivers and the families in our sample. And as we mentioned, and as Stacy has said as well, these are issues that are caused by generations of systemic racism, disinvestment, and economic exclusion. And these are structural forces that are reflected in the GIPRAs, but if we're to affect them, they should be measured by better measures of structural determinants of health, which I'd be happy to discuss more in the panel. And and they will not be fixed with a 5-year grant or even a 10-year grant. This kind of change takes much longer term investment and strategic community-led solutions and capacity building. And therefore, that's what we've been focusing our social determinants of health work on in the West LA Promise neighborhood.
Fantastic. Thank you so much for that great presentation. Really dramatizing the enormous social challenges and economic challenges that are facing the communities where the Promise neighborhoods are working. I wonder if Professor Stevens, you could turn on your camera too. Come back with us for a little bit of Q&A here. People should feel free to put their questions into the Q&A for us. And I'll get started with the first question. I remember when I was trying to work on housing as a pediatric resident, we had kids who, it's very clear, their home situation was the most important thing for them. One of my patients I remember quite well had to live strapped into a stroller even though he was 2 because the family was doubled up with another family. And if he was running around, then they might get kicked out and become homeless. I remember that very vividly. But as we started to work on that, we got pushback because people said, you're pediatricians, you should stick to your lane. You should stick to learning, if they have asthma, how to treat the asthma medically. And I wonder, as these Promise neighborhoods have recognized the role of social factors, social determinants, what have been what's been one of the biggest challenges, if you could maybe pick one of the biggest challenges of getting people to see the connection between these social factors and the outcomes that you're seeking? What's been a big challenge in either getting people to recognize it or mobilizing against it, given the context of the Promise neighborhoods work?
I can go first because housing is such an important issue in our population. I think one of the biggest challenges is that our systems of support, our systems of government are so siloed. And so, the Office of Homeless Services and other, homeless or housing providers throughout the city are not knitted into any kind of central system where housing needs are identified and resources or referrals to various housing solutions can be shared readily. That exists out in the community a bit better than it does in the community, but than in the school. But linking the schools into the process of identifying housing needs for kids and then connecting their caregiver or guardian to existing housing services has been quite a challenge. And so there's lots of hidden and very, overt homelessness and housing instability. And as a result, kids bounce around to different schools as their housing situation changes as well. So I think, we're working on these kind of cross-sector, cross-system, resource directories, data, shared data systems and solutions so that we can kind of break down those silos and be able to do those referrals across system.
Got it. How about you?
So I'm going to agree with Amy in the sense that definitely housing is probably one of the most challenging areas to face. And to me, it is the number one thing that we should be addressing. And so I don't think people really recognize and understand the extent that poor housing conditions contribute to health and educational outcomes, poor outcomes, right? And so that's language that those of us who are, doing this work around the country in Promise neighborhoods, and also those of us who are in public health, have to be clear about that messaging to our politicians, to those who are designing our architectures, who are designing cities, urban, folks who are working in the city, to urban designers, those physicians, and other healthcare providers, so that folks are understanding the great risk that unhealthy housing and how it contributes into many of the outcomes. It is difficult for families to live in deplorable housing conditions and have to wait years and years to potentially move somewhere else. And so even in figuring out the infrastructure around what's happening at our city level of being able to move families to better homes, is fraught with many challenges and many barriers.
What are
So
some
it's deep
strategies?
rooted. It's deep rooted.
Yeah, it is deep rooted. You've identified it. You're seeing the consequences everywhere you look. What do you do? Where have you had any success? What's the, how can you give people who are working on this, and we have almost 100 people listening in now, what would you tell them if they're, hitting their head against the same structural, challenge? What have you done that has made a difference?
I think one thing that's been very successful is that Drexel has a community lawyering clinic that deals with tangled title and other legal impediments to for folks being able to stay in their homes. I think that, and also I will point to medical legal partnerships and various service delivery settings are really excellent at teasing out these various, almost logistical barriers, but that need quite a lot of attention to be able to deal with. And also one of our schools has a very intentional housing program that's funded through our community schools program in the city of Philadelphia, which is funded by our sugar sweetened beverage tax. So I think that's been an excellent use of city funds to be able to focus in that school specifically on housing instability and direct to caregiver resources directly from the school about housing.
Great. Professor Stevens?
And so I know that University of Maryland also has deep partnerships with the law school and also with School of Medicine to address these issues. But I think where I have found great resource has been in the community, has been those grassroots organizations that have kind of sprung up, who are working on this and addressing these housing issues themselves as an organization and in collaborations with others. So I can say that we have barbers who are investing in repairing homes and making those homes available to families, or some of our expected families. I can say that there's a group, Black Women Build, who has come together and they're looking at how they can partner with churches and also with our Promise Heights and rehabbing houses. And we're looking to do that and have families who are in our schools then live there. So I want to make sure that we are not overlooking the gifts, skills, talents, and abilities that exist in communities. Residents live in these communities. They've been in these communities for generations. They have a networking capability that is phenomenal, right? I see this every day. It's amazing. And so it is up to us to deeply engage. When I said in that pause, Dr. Sharfstein, to really pause and quiet from our privileged academic spaces where we think we know everything, to really find those jewels, to find those resources in community and partner with them in different ways.
Right. Well, I've heard you talk about how that is one of the keys to the success that you've had in this, incredible effort. Could you talk about how you do that? How you quiet things down, listen, get out there? What's the mechanism that you use? How does that work?
So, I mean, I'm really grateful that our team has worked in school systems. And so in a school environment, which many of you know on the call, they're extremely noisy, bombarded by noise pollution and in the communities in which we live. And so we have really studied and practiced how to quiet ourselves, to do deep breathing and meditation. We share that as a team. We share that with the residents that we work with so that we can get clarity. We can really address our dysregulated central nervous systems, and so that we are able to really hear when residents are speaking and believe residents with what they're sharing and partner with them, allowing them to lead. They are clear about the changes that they want to see and are extremely resourceful. And so I will say that is just one way that we have, when we're doing our work very intentionally, we are partnering first and foremost with families and those organizations who are doing the deep, long-standing work, not the ones who may be the shining star when we come in and they're identified as these stakeholders, with other folks. And then we are showing up consistently over time, establishing trust and recognizing that this relationship is bidirectional, that we don't have all the wisdom and knowledge that is required to really make the change across these determinants of health, that many of those resources and knowledge and wisdom come from residents over time. So that's, when I say really quieting that central nervous system, I'm really speaking to that, because we have learned that this is not only something that we're implementing, but other organizations across this country are implementing these.
Josh, before
Sure.
I would like to address this as well, because I couldn't agree more. And given that we're almost out of time, I think that this is the most important point to be made. Not only that, we do very authentic, genuine partnership with all of the community-based organizations who essentially are leading all of this work. We are wrapping our resources and support around them to move even greater capacity into their agendas, their infrastructure, their deep and better understanding of what's going on in the community. But I will say that with these large federal grants comes the opportunity to provide career and workforce development funded by the grant. So our study personnel are all community residents. Many of our full-time staffers are community residents, and they're the ones who are providing the leadership on this grant and helping to think through how we can accomplish what we are required to accomplish through this grant, but more importantly, how to sustain this work out into the community in these long existing anchor institutions. And that is a very long process, something that takes much longer than a 5-year grant. And so something we've been doing before, during, and after this. But honestly, I think funders really need to think about how to sustain such long-standing work that has ups and downs. And big, large federal grants can be somewhat disruptive and can pull folks into directions that may or may not address their agendas. And so that's why we as funders, or we as backbone agencies, really need to make sure that it's supporting their agenda. So I couldn't agree more with you, Stacey.
I want to also add one more thing. And so one of the things that has led to Be More Healthy Babies citywide, and also within Upton and Druid Heights, to be so successful, is because our funders were flexible. Care First Blue Cross Blue Shield has been flexible with us as we have come into communities, learn about communities, made steps to back up to hear communities. They have been flexible in their outcome, their expectation of deliverables, and consistent in their funding. And so they have funded us, as you know, Dr. Sharfstein, for 12 years. And so anytime we're talking about making a significant, substantial change within many of these communities, it is going to take 8 to 12 years.
I think that's a great point. And I was actually going to jump in to talk about when that funding started, because what happened was, at the time I was the health commissioner of Baltimore, and I think very close to each other, there was the announcement of the very high infant mortality rate that you mentioned, with the enormous racial disparity. And there was an announcement from Care First about all the great grants that they were giving to little individual programs. And I read those two things next to each other, and I felt like, a grantor can take credit for little projects, but doesn't the grantor really want to see community progress? And so I went to the head of Care First, and we sat down and I showed them the two things. And I said, you're getting, your press release for individual projects, but those grantees don't necessarily feel responsible for a community, and they're not necessarily from the community. And so would you consider changing the way you give grants like this in Baltimore? And to their credit, they did. And they were suddenly open to the idea that they were investing for outcomes. And in order to do that, it required a totally different model than investing in specific programs. And out of that came the idea of focusing on particular parts of the city. So it has been, for me, having been there at the beginning of that, just an incredible thing to watch and cheer on the work that you all have done, because it really does validate that, and it reflects so well on the funders, which comes up to one of the questions we've gotten here, which I'm interested in your take on, which is accepting the fact that you want to have this process of working very deliberately and calmly and intensely with communities. How do you engage when there are different opportunities, and how do you bring in anchor institutions, federal grants, big programs that have the potential to be very helpful, but also the potential to disrupt the basic, trajectory that you're trying to create of improvement, just because they come in with, all kinds of expectations, some of them may be unrealistic, et cetera, and their ways of doing business. How do you integrate that? Because you want to bring in more resources, but you don't want to change fundamentally what you're doing.
And so I will say this, and my leadership who's listening will agree. When I'm reviewing those grants and those entities, I've taught us to be highly selective. And then we have turned away. We have not applied for certain RFPs when they've come out, primarily because we know that the organization, the funder, is not going to be flexible. It's going to be about what they're wanting to see. And we are determined what we do know in order to be effective, to disrupt this intergenerational, this historical stuff that we've been talking about, racism and how it showed up in the lived environment, is that it has to be centered and focused on what it is that we're hearing residents say. Residents are clear. And so we are very selective.
Right.
And I'll just add that, we're clearly much farther along in the process, not farther along, much more recent to this process than the coalition that Stacey's talking about. And for us, it's been about investing in community-led systems of research, priority, intervention, planning priorities, and oversight. So we're supporting the development of a community research review board so that the community has the say over what studies, what grants are allowed to come into their borders and collect information from their residents and how it's used. And, I think that we don't, as a society, put enough investment in the development and in the support for community systems, because communities to prioritize grants and to prioritize studies and to prioritize and plan for their own solutions is really the only way we're ever going to make change. And so we really need to consider as a society where we put our investment into. Who are the experts? And the experts are those who have long been living in and serving their own community.
Right, and also what other entities, what other networks, what other grassroots organizations exist in that community that are also being funded and are responsible for part of that lift as well. We recognize that everything doesn't have to happen through University of Maryland, Baltimore.
Right.
We're clear about that. In fact, with Promise Heights, it's only because of our deeply partnering with those other organizations, because we don't do everything. We don't have the capacity to do everything. And so therefore it really requires us to have deep collaborations with folks.
Yeah, and to recognize and to build from those existing assets. Support those.
Well, we just have a couple of minutes. I want to ask this last question, which is for people who are excited to do this work, but also realizing how hard it can be. What would be your closing message to them in a few seconds? How would you pull this together for someone that, it's their first job on the team? They could be coming from within the community. They could be someone coming on the research side who is not from within the community. What would you what would be the key messages you would want to deliver?
I think I would just say that the work that you do should be at a systems level. You can't fix homelessness with simply a housing program. Housing interventions need to be, woven throughout school, school environments, school services, work site issues, faith-based organizations, community-based organizations. You can't fix any of the social determinants of health with a single program. And I think we have that kind of attitude in this country, right? We'll fix diabetes with the diabetes program, but it takes, thinking about diabetes and all the different lived experiences and ways that folks experience diabetes and its consequences, or housing instability and its consequences. And that's where we need to focus the solutions.
Great. Stacey.
I would just say you started at the perfect time. Because if we had this conversation like 2 years ago, everyone on this call was not aware that health is a human right, that racism is a contributor, is a determinant of health and a contributor and influencer of a lot of the areas that we talked about. And so what better time than now when you have more professionals who are doing the work and who are interested in doing the work, and you have residents who are definitely at a point of being fed up pretty much with their lived conditions. What better time than now to move in to do this work? So I would that person be extremely hopeful and optimistic, because this is the time, this is the season of leading disruption.
Well, that is a fantastic note to end this super panel with. I hope all of you realize what a pleasure it's been to really hear from people doing incredible work in Baltimore and Philadelphia, and really thinking strategically and effectively about how to address the social determinants of health while achieving important health and educational outcomes. So please join me in thanking them. I think I have to find some way, because we can't ask everyone to take off their to turn on their camera. So I'm just going to have to do this by way of saying thank you here in my little Zoom box, my Zoom trick, to appreciate both of you for your time today, and everybody for all the work that you all do and for joining us. Thank you very much.
Thank you.
Thank you.